It's a pleasure to be here. And I see many diverse people from different areas, and I hope this speaks to all of you, because this definitely speaks to me in a significant manner. And although this is mainly focused toward intended for emergency departments, however, I am certain EMS providers as well as other healthcare providers would benefit from this knowledge as well. So I welcome anybody's and everybody's input, discussion points, and comments and questions, please. First of all, I have no financial conflict of any interest of this presentation. As I stated, I'm the co-chair for Wisconsin EMSC. Okay, so I'm just going to start with the story of a 6-month-old baby who was sick. Apparently, this baby got sick, fever, vomiting, and got lethargic. And parents felt the baby was having difficulty breathing, and they were very panicked. So they called an ambulance to take this child to a hospital, a local hospital where 24/7 hospital, general hospital, and community. And when they arrived to the hospital, the physicians took a look at the baby and felt the baby was really sick, and ended up doing many tests, including spinal tap. And they saw this CSF, clear fluid, turbid fluid, and they have ultimately decided that this patient's baby has meningitis. And when this was told, the father, as usual, would ask a question, so what can you do to take care of her? Unfortunately, or surprisingly, the answer came in the form of, we don't have appropriate size of equipment of expertise to fully take care of your daughter. And because we have we cannot do much for her, she will likely suffer, she will die or suffer severe brain damage. I don't know if you're out there, but what era of medicine do you think this case is from? I don't think you don't need to all chime in, but this specific case occurred in 1984. And I'll come back to this in just a bit, but I'll just go to some objectives that I want to lay out for the discussion here briefly. So we're going to just learn about the history of pediatric emergency preparedness. Although we are focusing more on emergency departments, but this does globally go across the pre-hospital setting, ambulance, as well as other EMS providers as well. And then we'll try to understand what the current status of pediatric preparedness is, not only statewide, but nationally, and then know the pediatric readiness recommendations that are out there, and sort of give you some ideas as to how you can improve your pediatric readiness for your in your setting. So I'm sure you know this gentleman. This gentleman's name happens to be Patrick DeLeon. He was the chief of staff for Senator Inoue from Hawaii. And this Patrick DeLeon was the father of that 6-month-old baby who suffered meningitis. And in Virginia, where he had to take, when he was in Virginia, took his daughter to a community hospital where she was diagnosed with bacterial meningitis. And they were told that there was no expertise and equipment to take care of a little baby of this nature at the hospital. Faced with this significant dilemma and barrier and scary situation, fortunately, miraculously, his daughter survived. And not only did she survive, but she grew up to be a practicing lawyer in Virginia area too. So resilience of pediatric patients is echoed here, however. From this experience, and he conspired with Senator Inoue, along with Kelvin Sia, who is the father of children of Hawaii, who was the American Academy of Pediatric chapter president of Hawaii. And they contacted this senator, I'm sure you know this senator, Senator Orrin Hatch from Utah, and then C. Everett Koop, who happens to be a Surgeon General at the time. So they conspired together to form and passed a legislation that introduced emergency medical service for children in 1984. And this was funded through a national program. And basically the objective of this organization was to ensure the state-of-the-art emergency medical service for ill or injured children and adolescents, and to ensure that the services are well integrated to all the emergency medicine services, not only pre-hospital to the hospital, and to ensure the entire spectrum of emergency services are provided from the beginning to the end. So this very robust goal in mind, EMSC was taken shape, and then they were left to do what they do. And so in 2001, they were really left to kind of see what EMS has done and what the status of emergency medical service for children, how pediatric preparedness has, how far they have come. So a study that was done showed approximately 31 million pediatric patients visited emergency departments in 1997. And of the 5,300 EDs that were surveyed, only 2% or 105 had pediatric emergency departments or pediatric ICUs. However, 76% of these facilities were admitting patients, and almost 90% did not have any pediatric trauma service, and yet 25% were admitting critically injured patients that are pediatric patients. So realizing this sort of disparity and the lack of preparedness, they came up with some recommendations that we should focus on these areas: administration and coordination of pediatric care, and then qualifications of providers, physicians, nurses, and then really also to recommend quality improvement process that are multifaceted and that's ongoing, as well as existence or development of policy, procedures, and protocols. And also support services, for instance, having radiology departments that are pediatric friendly with a LARA concept, and then medications and equipments that are pediatric sized and doses. So this recommendation came out in 2001, and in 2003, Dr. Gaushe Hill from California did another survey to look at how the recommendations are being followed. And her findings show that approximately 29% of the surveyed hospitals showed that approximately 90% of the pediatric patients are being seen at non-pediatric hospitals. This data, actually this percentage still fairly holds true to this day. I think there's a little less of this, but approximately 80 to 90% of the pediatric visits, emergency visits, occur at non-pediatric hospitals. And about 75% of the emergency departments see less than 7,000 patients a year, and about 60% were aware of the 2001 recommendations. And the presence of the pediatric physician coordinator as well as pediatric RN coordinator were less than 20% each. And then only 6% had all the equipments that were recommended by the previous guideline. Other people were interested in this fact, and then two studies that were published in 2006 show that about 119 million visits of adults as well as kids occurred in 2004. Approximately 20% were children, and 50% of these emergency departments seeing less than 10 children a day, which goes to show that how much of pediatric expertise or ongoing processes are present in these emergency departments when you only see 10 patients a day. So one has to ask the question, how is the quality of pediatric emergency care in these hospitals that occasionally see patients of a younger age? So one of the landmark proclamation that was reported by Institute of Medicine report back in 2006 had a very significant impact on how emergency medicine is being recommended as the improvement. So they noted that there's a significant lack of pediatric emergency departments throughout the country, and that specialty trained staff are lacking as well. And there's lack of transfer agreements, and CME for pediatric emergency medicine is not required. And then disaster preparedness does not regularly include pediatric patients. So noting all this, the recommendation goes on to say that we really need to pay more attention to children in all aspects of emergency care. That includes standards, care, and research as well. So given a choice of hospital scale location, when you have a sick child, do you go to the best emergency department for the kids, or do you go to the biggest emergency department, or you go to the small or the closest emergency department? So these are the questions that a lot of the parents and the family have to answer with a sick child in front of them, as well as a lot of the pre-hospital providers. So what are some of the benefits of having specialized pediatric emergency departments actually taking the time and trouble to get there? The advantage are obviously level 1 trauma centers such as American Family Children's Hospital or Children's Hospital of Wisconsin have that comprehensive trauma resources to really take care of a patient no matter how injured they are. And then there's a presence of pediatric intensive care unit where there are significant resources to really take care of a patient who's really, really sick. And the patient does not need to be transferred out, and all subspecialists are available. And so these are the benefits of going to a pediatric specialized emergency department of the hospital. The downside, obviously, is depending on where you live. You have to travel a long distance to get there. There may be a longer wait. There may be a longer stay. So, given these limitations, it was felt that trying to get all these sick patients to a specialized pediatric emergency department is not feasible throughout the state. So, Ben, when you go up north, how long does it take for you to travel up to the tip of the Wisconsin?
I mean, it's several hours on a good day, if not longer with weather. You know, it's not uncommon for 5 or 6 hours to expire before I get to my destination.
Great. So the question is, how can a sick child travel that many hours to go to the specialty pediatric emergency department? That is not feasible. Thus, I think a reasonable consensus or at least recommendation was, so why don't we help all the community emergency departments to be really do what they do best and really help them prepare for pediatric emergencies. So a guideline came out in 2010 that it's supported by American College of Emergency Physicians and Emergency Nursing Association to really state a guideline that says how to take care of pediatric patients in the emergency department and how to be prepared. And this checklist that was published, and there's I have the link here, and I'm not sure if this will be available. Will the slides be available for the? So we'll have this link available for you. But this is a checklist that came out back in 2010, but has all the items that they're recommending, and it's actually I think it's about 7 or 8 pages. This is sort of our Bible to really prepare for pediatric emergencies. So if you are familiar with this, that's great. If not, I would hope you take a chance, take a time to take a look at this document, which will really help you guide preparing for kids. So after that guideline was published, a pediatric readiness project that ensued back in 2013 did a national survey of all the states with varying degree of participation. And they surveyed tried to survey all the emergency departments. And I think the average surveyed was approximately 86%. No, that's the Wisconsin data. I think they surveyed close to 80%. In Wisconsin, we had 128 emergency departments at the time, but 111 responded, a response rate of 86%. And our score, best out of 100, our state scored 67. All other state average hospital nationally was 69. So we were pretty in the ballpark. However, as you will see, there are some items that I think we need to take a look and see how we can improve. The specific sections of this preparedness survey included guidelines for administration and coordinations, and we scored, of all the other sections we scored in Wisconsin 8.7, and where the national score average was 10, so we did not as well in this area. But the physicians and nurses and other health care providers, as well as guidelines for improving pediatric safety in the EDs, guideline for policies and procedures, and other equipment supplies, we did fairly comparable to national average. However, this doesn't mean that we are fully prepared. So if we take a look at some more specific data that I think we can focus more on, the presence or the absence of the nurse coordinator in the emergency department for pediatric specific issues, clinical issues, Wisconsin scored 48, national average of 59, and that we are definitely lagging behind the national average. Physician coordinators are about the average. Still, only 50% of these facilities had MD coordinators for pediatric care. RN competency evaluation, physician competency evaluations are still fairly lacking for physicians. But I think one of the critical findings here is that the identification of QI measures is quite lacking in Wisconsin. At least that's the survey says. So we are 30% of them had idea of any QI measures that are ongoing for pediatric specific issues, whereas the national average is approximately 60%. So we're lagging quite a bit. Weighing in kilograms has always been a hot topic, and a lot of hospitals are now converting to kilogram measures due to dosing errors that could potentially happen. However, we're still at 77%, better than national average, but still 23% of the hospitals are not weighing in kilograms. And recording in kilograms even worse in Wisconsin. And also the hot topic of disaster planning does not include specific pediatric protocols, and 35% of the, only 35% have pediatric component in the disaster plan. And then ideal QI measure that I mentioned before, we're lacking there. So I think we are about the national average, but I think we still have some more specific areas that we can focus to improve. So in order to combat this, the national EMSC has come up with a program that called Pediatric Readiness Quality Collaborative, which is a 2-year project to really improve some of the 4 weakest areas that we need to address. That is measuring and documenting in kilograms, and development of any abnormal vital sign notification to providers, ensuring interfacility transfer guidelines that are family and patient-centered, as well as establishing disaster plans that include children. So these are the 4 measures in this project we'll be addressing to obtain approximately 10% improvement in the selected in the score. So currently we're in process of being a part of this Pediatric Readiness Quality Collaborative, 2 training sites. The main site that organization that'll head this will be Emergency Medical Services for Children, Wisconsin EMSC. And Erica Kane will be coordinating this Wisconsin state project. And Beneath and myself, as well as Lauren Brown and Matt Pinasol from Children's of Wisconsin will be involved. And there are, I believe, 14 hospitals that are selected to be an affiliate sites for this. So I don't think they've been informed yet, but we're actively trying to finalize this project, and we'll have announcement and we'll be able to get going on this. So as far as the Wisconsin Pediatric Readiness Program, we have tried hard for the last 10 years to really gather up a program that identifies hospitals that are prepared for pediatric patients. We've tried many different ways to make that happen, and I think it's a very challenging and significant barrier. But we will continue from the Wisconsin EMSC to continue to troubleshoot and try to come up with a Wisconsin-specific pediatric readiness program that could recognize all the hospitals for their pediatric readiness. So this is soon to come. May take a few years plus, but we are working actively to try to come up with a program to get all the emergency departments in the ED in the Wisconsin to be ready for pediatric emergencies. Now, specifically focusing on some EMS data, pre-hospital data, there's not a lot. However, this data states, this is from back in 2008, the essential pediatric equipment. So there is a document that recommends what kind of equipment should be on board an ambulance, a rig, if you will. And at the time, the essential pediatric equipment that we've surveyed, BLS units had 42% of the Wisconsin had BLS units that are equipped with all the pediatric equipment versus national of 69. ALS unit had 25% versus 71 nationally. And then written inter-hospital pediatric transfer agreements were 48%, and the inter-hospital pediatric specific guidelines were only 4%. So we still have a significant improvement that we need to make in the EMS arena. I think there's a new survey data that will be coming out that is still has not been released yet. So this is the joint policy statement from back in 2000, I believe 2009, right? That has all the elements how an ambulance should carry all the pediatric equipment. So if you could, when you get this presentation, you can click on that link and should be able to provide you with a listing of your ambulance equipment that's recommended. So most updated, so one of the survey, at least the information that's been released. Thank you, Erica. There are two new performance measures from National EMSC that tells us that looking at the EMS services to see whether an EMS service has a designated pediatric emergency care coordinator or not. If you look at the data on this, the survey shows approximately 21% of the Wisconsin EMS services have a designated pediatric care coordinator, whereas the national has approximately 23%. So we're about even at the national percentage, but we still have a lot of ways to go to make this all happen throughout the entire services. And then the next performance measure that we are bound to exercise is to see if there's any process for EMS providers to demonstrate the correct use of pediatric specific equipment. This is to how the services could go on ongoing training to demonstrate the use of pediatric equipment. We're still at about low 20% in Wisconsin and 24% nationally. So we still have a lot of improvement that we need to make in these two measures. So having these data and having all the historical facts, I think it is important to really look at ourselves and see, are we ready to take care of pediatric patients who in case of emergencies? So all for you in your specific organizations and healthcare setting, to really take a look at your setting as to see whether you're really ready for pediatric emergencies. And then understanding what the national guidelines are, and then really come up with a multidisciplinary team, including the administration and the providers and all the resources to really take care of pediatric patients well, meeting with the guidelines. And then I think this is another important part that I feel like we have not accomplished well, is to really secure a collaborative effort to really communicate and to be able to open channel with all the emergency departments from our specialty, meaning they should be able to call specialists anytime, any day, anytime, get support to consult, and having these relationships will really, really help the care of pediatric patients. And then Wisconsin EMSC, as I've stated, we are here to really improve the emergency care for pediatric patients within the state of Wisconsin. So we have meetings, we have many resources on the web, and Erica could show you many different resources, and all the resources that I've mentioned are listed here.